everyone, to this session on hepatitis and TB. My name is Kerry James. I'm Chief Executive of the World Hepatitis Alliance. And we're really thrilled to be having this session, the first dedicated session on hepatitis and TB ever at the World Hepatitis Summit. So thank you all for joining us today. Maybe I'll just ask my panelists to introduce themselves first. So Lucica, would you like to just introduce yourself?
Yes, so thank you. My name is Lucica Dițiu. I'm the Executive Director of the Stop TB Partnership. It's a start. It's a very shy start, I would say. If we count how many we are in the room, it's a bit disappointing. But it's very good because it's very gender unbalanced. So we have very many ladies, and I tend to believe that when women put their heads to something, it's happening, while men will organize another meeting. So I hope that the 2-3 gentlemen in the room will become maybe a few more. But I'm very happy, and thank you all for the time for being here with us today. I think it will be a very intimate chat. Thank you. And Kerry, thank you for organizing this. Yeah.
Thank you for coming.
Yep. So yeah, firstly, thank you. Thank you for having me. I'm Ahmed Khan, and I'm leading the Innovation and Implementation Unit at a not-for-profit entity in Pakistan by the name of Association for Social Development. So ASD works on a range of communicable and non-communicable diseases in Pakistan, and they've been working since 1995. So yeah, it's a pleasure to be here, and I hope for this to be a fruitful session.
Great, thank you so much. So we have a few speakers, we have a few presentations, we have one video as well. And then we're going to kind of open it up to the floor to have a discussion about the crossovers between TB and hepatitis and how we can work more closely together. And if you guys have experience of doing that in your own countries, we're really eager to hear that. So I'm going to hand over to Lucica for her talk. Thank you.
So thank you so much. First of all, I want to say that everybody will get chocolates. This kind of chocolates, which come from Switzerland in most of my meetings, are a metric for how well things are attended. And this morning, we will give more to everybody, but so that's why I think I was even speaking with Kerry before. Is not the time, because we will lose time reorganizing. We could have stayed in a circle and even introduce ourselves and have a more, interactive discussion, sort of Alcoholic Anonymous chat than this. But the setting and everything is a bit more complicated. So my name is Lucica Dițiu. As I said, I'm a medical doctor. I'm a pulmonologist, and the Stop TB Partnership that I lead for the last 11, 12 years, for a long time, is a United Nations hosted entity. And we are based in Geneva, operating with a board and so on, and with a large team, I would say, for my taste, 120 people. These are things that you actually could not care less. What is important is that one of the teams that I have that is pretty large is called Global Drug Facility, and is the one that secures commodities, drugs and diagnostics at a pooled procured price and at a very low price for tuberculosis. And why I brought this into the discussion is in TB for a long time, we suffered from a very similar bottleneck or challenge as it is in hepatitis, a huge difference between estimated people sick and the number of people diagnosed and treated. And we pushed some very strong campaigns in finding everybody that has TB. And obviously diagnostic and access to diagnostic of everybody is one of the most important matters, but price is also very important. And I found out that the GeneXpert cartridges for hepatitis are at around $17, $18. The TB one, we managed to push it down to 7.8. And I think that there are discussions. It was a concerted effort in dropping this price. You might not be aware, but actually Stop TB together with MSF and Partners in Health, as well as Treatment Action Group, we pushed, and other civil society partners, we pushed a big campaign, Time for $5, based on the fact that there is some assumption that the cost of the company Cepheid to produce the cartridge is around $3. So a $5 price per cartridge makes sense. We are not yet at 5, but I think we are far better than what I heard. And there were discussions about dropping the price for cartridges, not just for TB, but for other diseases as well. So I think that's also something we can look into it. Now, hepatitis and TB, I don't think, we will do here the science, but I want to say, or at least that was not my plan, but I want to say 3-4 things. There are a few studies. There is a Cochrane review around the association between hepatitis B and C. I actually have a printed version here, hepatitis B and C with tuberculosis. And it was commissioned by WHO TB program, and it's unpacking per region, it's unpacking the risks. It's a very thorough review, looking at, I think, around 130 studies that were done. And the outcome says that indeed it will make sense to offer testing for hepatitis B and C during the TB treatment. It shows as well the fact that the treatment outcomes for people with TB are far worse, with at least 20% for non-HIV. For those that are TB and HIV and hepatitis, the treatment outcomes are as bad as 50% less than what you observed in the non-hepatitis, people living with HIV. So dramatic impact, okay? As I was explaining yesterday, this was, as I said, an initiative from the TB side in pushing forward and trying to see how we can ensure that the links with hepatitis will be, highlighted and what can be done more. I think it will be very important if the hepatitis community will also look at what's happening with the people that have as well tuberculosis, because I know you already do that, looking at people with HIV. So I think it will be very important to start exploring these approaches. Now, the next point that I want to make is this. So I don't think there is too much doubt or debate on the fact, or should be, on the fact that we can do much more integrating and pushing agendas together. It will be very difficult going forward, especially if we continue the siloed, isolated approach for diseases. And I'm not even limiting myself to hepatitis and TB, but in general. Unfortunately for us, that time passed, or fortunately for us, that time passed. There was a time, that was started very much by the HIV movement. And it was pushed by the fact that for a very long time and in the beginning, the HIV community was coming from the rich countries, people that were very visible and have political power or power to influence political will. And because of the PEPFAR, the HIV movement created a sort of parallel system in countries, in many places. There are countries still now in which the National AIDS Commission that were created and existed for good reasons were linked directly to the president and the prime minister. Sometimes the Minister of Health was not even aware about what was going on. We know of ministers of health that were reaching, at least I, to myself 3-4 times recently and asking if I know what's happening with their National AIDS Commission there. So that was a very verticalized, very contained, and very much focused on that. And following that model, I have to say that because of their very infectious disease nature, both malaria and TB kind of jumped on that wagon, even though I have to say that on TB, as well as malaria to a large extent, the work is done through the country's health systems. There were never a PEPFAR, so that's why we couldn't afford, if we had money, probably we would have, to create another parallel, very verticalized and very, very contained system. So TB works through the national systems, and the funding that is getting into TB response is domestic or coming from the Global Fund. These are the only two. USAID is giving some funds, but it's around $300-400 million a year. for the TB response. The global fund is at around $700–800 million a year. And then are the domestic resources. And the domestic resources are how they are. So now, like kind of when we wake up, we have a movement and so on, the money are little. And climate change is there and wars. And it's like people are having so much on their agenda that it's very difficult to make the case separately. And going and saying, hey, minister, this was TB, but look, this is hepatitis, this is syphilis, this is, cardiovascular. So the more smart ways of integrating and doing work together we will have, the better it will be. Again, bilateral. It cannot be just one community after each other. So, pushing the other one. It has to be bilateral. So from the TB side, as I said, we are not a big funding structure, but we provide grants to smart ideas in countries. It's one of the teams. One of the teams provide the drugs. It's called Global Drug Facility. We have another team called TB Reach that is a Canadian baby, and we provide funding for innovations in finding people with TB. And we went through a lot of things, from procuring donkeys and horses in Lesotho, because that's how the government thought they will find their people with TB. They didn't want to have more labs. Everybody was constructing labs in Lesotho, but they didn't have people to provide the samples. So they said, we need transportation. And for us, and we provided that, then Global Fund stepped in, and now it's the government who pays for the donkeys. But it was a hell of a job for us in Stop TB. At that time we were in WHO, to be able to clarify for the UN bureaucrats why we need to buy donkeys in Lesotho from Geneva. So that was not an easy one, but when there is a will, you can do. So this team, TB Reach, did a lot of very innovative testing of tools or approaches. So on tools, we tested the mobile X-ray that with artificial, I think you can come closer or not. Just, it's a bit weird because we have this empty thing here and everybody is in the back. But it's fun because I never come in front because then I'm afraid people will ask me to say something and I never want to say something in meetings. So we tested different things. As I said, the mobile X-ray, which is reading the X-ray together with artificial intelligence, for you is like we don't care. But also any other miniaturized tools, and also any smart ideas on where do you find the people with TB. And this is like, because as much love we have for the guidelines and the recommendations coming from WHO or other institutions, they are all created in the capitals of certain countries, and nothing can compare with your own experience in the countries. I am a strong believer on the fact that unless the countries do their own thing as they want to do and following their cultural, structural systems they have, it will always resist more than what is pushed from Geneva, New York, or whatsoever. And I have many examples starting, and anyway, we don't go there. So I have many examples for that. We can go there later. But I just want to say that more and more we started testing approaches. And some of the things we funded was trying to find TB together with other diseases. And we have actually a round now. Initially, this was funded by Canada, as I said, but now is more and more other donors are putting money. So the UK government wanted to see integration. So we had a round of proposals in which NGOs, but can be also government, came with proposals in doing multiplexing diagnosis. Not just TB. Actually, I said, I don't want to see TB and HIV. For a long time, we did TB and HIV. It goes where it goes. It's actually moving very well. For those of you in the room, TB HIV is responsible for around 10% of the TB burden. TB and malnutrition is 24%. But we speak much less about TB and malnutrition. Everybody is TB, HIV, TB, HIV. So I said, I don't want to see TB, HIV. There is a lot of funding in that. Let's see other ideas. Let's see TB and malnutrition. Let's see TB and pregnant women. Let's see others, including hepatitis, including mental health, and so on. So we funded some of this. More is coming. So we will have more rounds. And depending on which donors we can attract, can be a specific round on TB and hepatitis. In some instances, TB Reach we got it in our face, as I say, because we invested in things that showed they don't work.
Yeah.
But still is good because you learn from that.
Yeah, of course.
It's too little. One of my dream conferences that it looks like my team finally puts up with me will be a conference of failures, of things that didn't work. Faria smiles because I think since you were with us, we speak about it and we still didn't do it. Because we often publish papers of that because we are worried that the donor will be like, oh my God, look what happened with my money. Well, actually, that's a very good lesson to take. And that's why TB Reach takes the risk. And after that, if something works, we either push it with Global Fund to be scaled up or even with the governments. And there are many, many examples of that. So one thing, and that's why I'm happy that you are here, and I don't know if that was TB Reach funding, but I know we did TB Reach funding in Pakistan, in Sindh for sure, in doing TB mental health and hepatitis. Because the idea is this, and I will end here because I know I took too much time. The situation is here. Once you have a chance either to have a group of people coming to be tested, or or campaigns, and I will go back quickly to the campaigns. It's a waste to do just one disease. When it comes to apply to, for example, through Global Fund of buying diagnostic tools, is a waste to buy equipment that do just one disease. But the drama is, this sounds good, right? The drama goes, and I tell you where the drama goes. When you buy this multiplex one, again, I tell you, it's at country level. Is the friction between where does the machine stay? I thought initially, I said, I tried to minimize it because it sounded petty. Not only where it stays, who pays for the maintenance? Who pays for it and who is responsible? And initially I was like, yeah, that's not an issue. But actually it is. I stayed in a call with Mozambique. I almost fainted. 1 hour and a half. They were fighting between the TB and HIV labs. Who use them more? And where is the budget coming for maintenance? Because also the bloody gene expert, probably, if this is online, they will not be happy. It's very expensive because they go country by country and the countries negotiate better or worse deals. And it's actually a big amount of money. So then it goes like, where are the cartridges staying? Whose machine is this? So that's why I kept saying yesterday about oiling the system, because it sounds good. Let's buy multiplexing machine. Where do you put them? So it needs to go hand in hand. It should not be pushed from one direction, but it is a waste. It's like we are all here confined. We should be tested for everything. By the way, that's going to happen. I have somebody testing us. No, I'm just saying that it will be, we are all here. We can do it, of course, we need to look at the cost and we look all pretty healthy, so maybe not. But we had a van in front of a hotel where we did a big meeting in the Philippines in the entire region with an X-ray machine. And I have to tell you that the ministers of health went there and took an X-ray as well, because they didn't do it in a long time. So it was very convenient even for them to say, okay, we are healthy. One of them was coughing, I was coughing as well, and so on. So for example, campaign mode of screening, even for the fact that, let's see, is it working or not? That's what I was saying yesterday. Why not do something? You test for TB, you test for hepatitis, you can do another HIV, you can do another test, which can be in vans, and you just do in a capital or in a neighborhood or in a small country, and use it as a proof of concept, properly done, and how much it costs and so on. But I will stop here, and I want you to tell what happened, what you guys did in Pakistan, with your permission.
Yes, of course, yes.
Thank you.
Yeah, once again, hello everyone. And of course, thank you, Luchka, for providing me the opportunity to share our experience. So for the few people that have just walked in, I am Ahmed Khan, and I will be sharing the work done by my organization, the Association for Social Development, which is a not-for-profit entity working on a range of communicable and non-communicable diseases in Pakistan since 1995. All right, so just to provide you a bit of context, in Pakistan, the different provincial disease control programs manage their own resources and their own interventions for diseases like hepatitis, TB, mental health, even HIV. So overlooking all of these provincial programs is a body called the Director General Health Services that is responsible for the governance as well as providing technical assistance. So integration of a disease intervention into general care implies obviously that the care protocols are adapted and a new set of staff roles and skills are developed. All right, so some of the past work that we've done includes we integrated mental health into DRTB care. That included behavior activation through counseling, through a tool-assisted counseling. This integrated mental health intervention included screening for depression and anxiety and was done for, of course, newly registered patients as well as those attending their follow-up visits. Additionally, we integrated smoking cessation into DRTB care, and this was done through a tool-assisted counseling as well. So some of our recent experience of integrating TB and hepatitis and HIV and hepatitis comorbid care includes includes hepatitis screening, confirmatory testing, treatment, and prevention for, firstly, for DRTB patients registered at the PMDT sites, which is a specialized sites just to manage DRTB, as well as people living with HIV at ART centers, which of course is meant for HIV care. This was done through the support of the Hepatitis Fund, so thank you. We are currently in discussion with the potential funding source to pilot TB and COPD comorbid care at public facilities, so hopefully we'll be doing that soon. All right, some of the major learnings through these experiences were firstly that extensive coordination is required for cross-program resource sharing and responses. So in our case in Pakistan, we developed a technical working group of the three programs, the hepatitis, HIV, and TB, which was of course under the Director General Health Services. And that has been the main mechanism for developing and implementing care in our context. So the technical working group was heading the deliberations and the development of the integrated care. So secondly, rigorous homework to redefine care protocols, staff roles, and skills is required, which again, in our case, was done with the help of the TWG under the DGHS. So I've just shared a few of the experiences of integrating care in Pakistan. So if anyone would like to more details, I'd be welcome to share those with you after the session.
Great, thank you.
Thank you.
And I have just the last thing that I want to say is that I have a printout of a summary of what happened as well in Pakistan in Sindh on the TB, hepatitis, and mental health that I have here, which comes with numbers and stuff like that. So I put this here. So I don't know, Faria, can I abuse you? No, you can just put this here, but start with the chocolates and circulate the chocolates as well, because I'm happy now it's a larger audience.
Yeah, exactly.
Back to you, Chair.
Thank you so much. So we also have, there's several things I'd like to talk about in both of your talks, but let's have because we have a recorded presentation from Zahid Islam from the Ukraine, from the Alliance for Public Health. Oh, sorry, I'm here. So we have a recorded presentation from Zahid Islam from the Alliance for Public Health in Ukraine, talking about how their hepatitis and TB programs work together. So let's play the video, please.
Hello, good morning. My name is Zahid Islam. I work with the Alliance for Public Health in Ukraine. Today, I have the privilege to present Alliance's hepatitis C microelimination work that we do in Ukraine. And today I'm going to focus especially on TB and HCV co-infected patients from the key population. So within the Ukrainian context, there is estimated 5% of the Ukrainian populations are living with hepatitis C. As you know, that Ukraine is one of the 12 high-burden countries in the world. And according to Public Health Center report from 2021, 14% of MDR TB patients are co-infected with hepatitis C, so which is really stable. And looking at the mortality also, I think we see that the HCV has the highest mortality comparing to TB and HIV. So Alliance started its community-based hepatitis C program, treatment program back in 2015, and providing comprehensive access to people from the key community. So far we have provided treatment to 12,700 patients from the key population. And these services, our program is provided through integrated services through NGOs, and especially focusing on PWD and their partners, MSM, and people who are on the opioid substitution treatment program. So we work with NGOs in the field. Currently, we have 14 NGO partners working in 16 different regions. And based on the protocol and also the design of the program, we trained social workers, NGOs, and a special educational counseling that provided under this program is one of the key area of support that we provide to the community who are on treatment. So in the left-hand side, you can see the treatment, sort of progression of treatment enrollment over the last couple of years. So especially for tuberculosis, when we are seeing, quite a lot of patients they are having multiple diseases at the same time. So we started treating hepatitis C among TB patients starting from October 2021. And as a preparation, we had, provided work on the guidelines and protocols to make sure that it fits within the project approach, and train the healthcare workers, social workers, especially on the drug interaction, as well as the educational part of the program. So we had enrolled 27 patients in 2021, but when the war started in the beginning of 2022, we actually lost 19 of those 27 patients, especially from the Kherson region due to Russian occupation. So still, overall picture is that most of the hepatitis C treatment program is catered for HIV population, people living with HIV. There is still very few TB because this is still very new. So we are kind of learning slowly, as you can see through the slide. I mean, number of HIV receiving Hep C treatment is quite high than tuberculosis. So as an outcome, we see that we had out of 235 patients, I mean, the big part of the treatment regimen was divided between two different treatment regimen, which is 12-week soft DAB and soft well, and 12 weeks of DAP. And there are only 8 courses were allocated, given for 24 weeks. And most of the people are coming from, nearly 65% are coming from PUD community, and 79 or 34% are coming from the partners of people injecting drugs. And notably, 51 patients who received treatment were actually infected with the triple infection, HIV, HCV, and tuberculosis, and 50 of them actually were on ART while receiving HCV treatment. and 70 patients had actually the quadruple therapy at the same time, which is HCV, ART, TB, and OST. And overall, only 41 patients out of 235 patients were on OAT during the time of treatment. And so as for treatment regimen, we kind of data shows that 96% of efficacy of the 12-week regimen of Sulfel and 84% efficacy of 12 weeks of DUC regimen, considering 103 people actually completed their SVR. So based on that data, this is the results we have. And the 10 people were failed in the treatment. So this is again mostly from 8 out of 10 patients were on 12 weeks of DUC regimen. And as an overall treatment effectiveness, we can see that on average 98% of adherence to treatment by the patients. So some key challenges, which is, Ukraine, in the country, we are still not, the WHO guidelines and recommendation are still not fully implemented. There are lack of experience among the Ukrainian health community in order to implement HCV, treat HCV among TB patients. And of course, low level of knowledge creates sort of uncertainty and barrier to scale up. On top of that, if a patient wants to go through government treatment program, they need to actually pay diagnostics out of their pocket, which is a major challenge. And diagnostics is not very cheap, as we all know. And another kind of barrier is that most of the patients treated, even within these 235 small cohort, are from TB inpatient department. And people don't want to come to, once they're released, they don't want to come back to do SVR. So it's, again, a challenge. And though limited, estate drugs are distributed or, channeled through specialized clinics or hospitals, so which also puts a lot of barriers for especially key population to access this treatment. So, but still we are working on to kind of see how to make this more available. This cohort was not completed, so there are more than 50 patients are scheduled to come for SVR in 2024 from the last cohort, but we are enrolling new cohort already beginning this year. So we hope to continue this work with support from Global Fund and other donors. So thank you very much. This is my last slide. Thank you.
Thank you, Zahid. I don't know if you're online, but if you are, thank you very much for that. And just, thank you all our colleagues in Ukraine for working under such difficult circumstances when we hope it's resolved soon. So now we've got a good amount of time for some questions, and I see lots of very clever people out there in the audience. So let's have a discussion about maybe what you guys are doing in your country, or asking about how we can get things started. But over to you, Stella.
Yes, good morning. Well, hopefully it's still morning or afternoon already. I work for WHO Europe regional office, and just wanted to share something that we've been focusing on. Luckily, usually HIV, hepatitis, STIs is separate from TB. Luckily in the region, because of probably resources also, we are all in the same team, and this brings some opportunities. So TB is with HIV, viral hepatitis, and STIs. Now, the European region is a high MDR region. So we have been supporting, our team, TB team has been supporting an operational research in the region. in 16 countries in the high MDR-TB countries of rolling out modified short treatment regimens, all oral regimens for TB. And I mean, all of a sudden an opportunity arises because there's so few drug-to-drug interactions between DAAs and oral regimens of MDR-TB that it has become possible to do this as a co-infection common clinical management. So we've put together also an operational research package for the countries to uptake to do MDR-TB, HCV treatment, co-infection treatment. And it's such a game changer because many of the results and the outcomes of poor outcomes of drug-resistant TB have to do with comorbidities, and HCV is one of them. In fact, up to 10% of the patients had challenges with, had hepatitis B and C, but C can be managed better. So, all of a sudden it has become an opportunity, and many of the countries are now looking at how to roll it out. And in fact, the WHO headquarters, Global TB Department, just issued a communication about changing the global guidance. So, and it starts from from the field. It doesn't start from the headquarters. So this has brought together, obviously, different groups of clinicians that before they didn't have much with each other. I will say that in many of the countries, the hepatitis groups are completely away from the TB group and from the HIV group. So this has brought up to light exactly the challenge of multiplexing. But the point of care test is with TB. They can do HCV now confirmation. So it's again an opportunity of using the TB platforms to expand the treatment for HCV. So just to say, it's already success stories in the region. So really excited to have this also shared with other regions in the world. Thanks.
Great, thanks, Stella. And there's even a regional coordination committee, isn't there, in Europe that covers TB, HIV, and hepatitis. I don't know, Tatiana. I don't want to put you on the spot, but you're a co-chair, right, for hepatitis?
And we are waiting for your engagement. Yes, there is a platform which we should use. I mean, when I say we, it is viral hepatitis groups should be a little bit more, let's say, active with the ideas, bringing ideas, and I was also thinking maybe this summit was a good opportunity to make a side meeting. Okay, this was a world, this was a global event, and we are talking about regional. Anyhow, I think that we should think in the near future when and how to organize a side meeting when a lot of people from TB and HCV, I mean hepatitis, are around. So just to meet in person. When we meet in person, it's much, much, much better than online. Right, Stella?
I agree. Great. Hands, please. Right here.
Good morning, everyone. My name is Chukwemeka Agwoch, and I work with China and Nigeria. I have one question and also a comment, but I'll start by saying, going through the agenda, coming to this summit and seeing this session, I was really excited. I was eager to hear, what the conversations would be like, and it has been really interesting. I will start by the comment to say that back in country experience, starting the hepatitis program in Nigeria, one game changer was the ability for us to integrate hepatitis testing into the GeneXpert platform, especially where you don't have the conventional testing systems. And that's creating access to that testing through the point of care has been fundamental to the success of our work. And coming to hear that, one take it a step further local collaborations between TB, HIV, TB, hepatitis, and case finding makes it even more interesting. And I was happy to see, especially in high burden locations for TB and hepatitis, it's interesting to have that joint case finding strategy. My question will be to the speaker, to that presented on, I don't know if he's online, but I saw that there were a lot, from the study that he presented, we saw cases of treatment failures with DAs, about 10 treatment failures. So I don't know what could have been the reason. And hearing Stella speak in terms of the TB and hepatitis correlation in terms of TB outcomes, could it possibly be the reason why we also had hepatitis treatment failures? I don't know, but just to confirm if he has an idea of why we had those 10 treatment failures, if there could be any further investigation, because it seems like quite a number of persons. So
Yes.
could the underlying TB disease be responsible? I don't know, but just to confirm.
Unfortunately, it doesn't look like Zahid is online, but I can pass the question on to him,
Okay.
unless anyone on the panel has any thoughts on why.
So I don't know the particular situation there, and the situation in Ukraine is also has so many specificities. But as I said from the review, it looks indeed that there is a clear correlation between the treatment outcomes that are worse for TB as well as for hepatitis due to the co-infection. That's clear evidence. And, if you are interested, I printed, I still do printed papers. I know, roll your eyes, very old fashioned. The review that speaks about treatment outcomes. So, I spare you the time to Google and find it. I can give it to you. So I don't know the specific things from his presentation, but we can for sure get it from him.
Yeah, of course, yeah. Any other questions or comments, or please?
Hello, good afternoon. Ahmed Sabri from the WHO EMER office. I have a comment, actually, it's not really to any of the panelists, but maybe they can reflect on it from their point of view. One of the challenges that we see is lack of encouragement to actually collaborate between the hepatitis and the TB programs. That's because the vertical donor funding. Actually, TB is very much well funded in most of the countries through the Global Fund. So it all comes to the issue of someone coming to me to take resources from me as a TB program. That's how they think about it. I have been to facilities where there are gene expert machines in some floors, and hepatitis program is in the below floor, and they really don't have any kits to test. While there are like expired kits happening in the floor up. So I'm not really sure what could be the encouragement, or if you have any reflections about this problem in general, I would be very happy to listen to this. Thank you.
Great. Do you want to start?
Yeah.
Mohammed, if you want to add anything?
Yeah, I don't think you were here when we spoke about this, but I will reflect. Where in which country you said no Pakistan? What? Emro. In general. Okay, yeah. So, yeah, I understand. So, 3 things. It's a myth about the funding for TB that is so big, because the funding for TB comes just in TB is just the global fund and the government. We don't have a PEPFAR, we don't have a PMI, we don't have that. And the amounts, I can tell you directly, are USAID is putting, as I said, 300 million a year, and Global Fund around 700 million a year globally. The rest is governments. I can tell you that there are countries in which the government puts single digits of what's needed in the TB response. And TB is an airborne disease. Okay, so let's remind that we are all at risk on this. But you made a very good point about the encouragement and the work. And what I was saying is before is the fact that there is very limited work at countries to see how these 2 diseases, if it is that we speak about them, work and are structured at the country level. Because as you rightly said, and as I know very well, they are in different departments in the ministries of health. They are in different structures. Some of them reports to somebody reports to somebody else. TB traditionally, I don't know where hepatitis reports, I imagine is with the infectious diseases. TB is separate. And very often TB reports to the deputy of the deputy of the deputy of the Minister of Health. very often the TB people are very happy, which should not be, that we go to countries, they have a chance to meet the deputy minister or the minister, you know, so we go, and I go very strong with a lot of noise just because it's unacceptable. So these two are not aligned. And that's why, as much as we speak about integration here in Lisbon, unless there is a push at national level of making sure that these two programs can speak, it will never happen. Because the money are circulating in a different way. And you gave a good example, and we spoke before you came in about the GeneXpert. It's a very good example. GeneXpert machines, the cartridges, we in TB pushed very hard. We are now, at least from the team that is in Stop TB called Global Drug Facility, we provide cartridges at $7.80 for TB. Hepatitis, I understand the cartridges are $17, $18, which is huge. So we should push together to drop the price. And there is already conversation that we have with the Global Fund and some of the activists to drop the price of GeneXpert cartridges for all. But that will not solve our problem. Because you buy, as you said, you buy the GeneXpert machine, let's say you buy it with the TB money. It will be in the inventory of the TB doctor, okay? Here is a response, whomever is that, in the Ministry of Health or the director of a TB center, right? It's a good example, at least they are in the same building, so maybe through some fights they can speak, but very often they are in different places. So we say here, and I am a big advocate for multiplexing diagnostics. You know, you buy a machine, you don't use it just for TB, you use it for HIV, you use it for hepatitis and other things. Actually, GeneXpert, as well as the model that is produced in India and is produced by MolBio and is called TrueNat, can do 40 different infectious agents. So it's like, wow. But then it depends very much who paid for the machine and under whom is signed, because if it's mine, and I don't want to, maybe I want him to do some tests, but not too many, because it will use the machine. The maintenance, he will say, I just used it. It's your machine. You pay for the maintenance. And I say, well, I disagree. You used it as well. The amount of energy that people spend to clarify these things just because it's not properly done and aligned in the country is incredible. So you have a very good point. And that's what I said, that the discussion should be from this kind of meetings of encouragement of them to work. And you heard what you said in Pakistan about and Islam as well, he said about people not knowing. But it has to be in the countries as well, even between TB and HIV and malaria, that even though with the Global Fund, there are different teams, different structures. And I said yesterday, for at least 4, if not 5 years, Global Fund is requesting for TB and HIV joint proposals to come from the country. So the proposal come joint, so it's basically me and him, we write our proposals, we merge them, we send to Global Fund, is approved. For the implementation, they are separated again. And there are different principal recipients and there are different sub-recipients and so on. And it comes from both sides. On the side of the donor, because it's an easiness to know who with whom you work, but on the side of the country as well, because when it's about money and accountability, people are very worried. So they need to know, okay, I paid, I have, people were fighting for paper in the printer. Who pays for the paper in the printer? In the same department. And I buy the paper for TB or with HIV money, I'm not giving to others because it's my paper. And if I remain without, they will not give to me. So that's why this is a hell of a job coming from us here, where we can do joint meetings where I agree completely should speak and come as a TB and HIV community, a TB, HIV and hepatitis community together, but it should be at the country to schmooze these things, and it's not happening yet.
Yes.
Yeah, Ahmed, I completely agree with your point. We've been facing the same problems in Pakistan, so I can completely relate. So I can't say for others, but what worked for us in Pakistan was involving the Director General Health Services, which is a body that overlooks and governs the individual the provincial disease control programs. So once we involved them, life became much easier for us. So yeah, that's my 2 cents.
It's the political will.
Yes,
know?
absolutely.
I don't know if you were yesterday in the room where India spoke about what they did. The moment you have them saying, you know what, it's the power of the Minister of Health can reorganize everything. Can say, I have a director and all these diseases report to him and you guys align. Change the budget lines and so on. But let's don't go into what keeps different streams also at national level, because there are a lot of, in my own countries, people were fighting between the clinicians dealing with TB and the epidemiologists. Who owns the data? I own, said the epidemiologist, I'm the clinician. So it took, I don't even know if they sorted it out now. Okay, Stella knows better, so they didn't, okay.
I feel
Data.
like we've been talking about this, the gene expert capacity thing for a long time, so maybe someday we'll solve it, but do you want to come?
Can I have just a follow-up on that? I totally agree. Thank you so much. I think it's all a governance issue. I think even if you ask the TB program to integrate, I don't think it's their decision actually to integrate. It's the people higher up. So I think our message also should be reflecting the discussions and the perceptions of the people higher up. And to be honest, we keep mentioning integration, but we really lack the vision of what integration means on the ground. Like really, there are so much implications on the healthcare facility. We don't really think a lot about adding the burden, more work to healthcare workers, how they actually see that, if they are willing actually to take that with their 2 hours or not, what the data flow will be like, how is the structure on the ground will be like. So I think we need really to think a lot more practical about the word integration. But thank you so much. Thank you.
Great, thank you. So we only have a couple of minutes and we have to finish on time. Is there any final comments or burning questions, please?
Thank you. My name is Ndukondunda and I work for Cepheid. So I will comment on that. Take the gene expert question here, just to clarify. I'm glad that everyone's trying to share the toys and no one likes to share. And the ownership thing is very, very difficult, even for us as manufacturers. So the one thing we have introduced is this cartridge cost, which is called access care. The biggest challenge was the machines being unutilized. So for us to encourage programs to share, we told them, pool the total country procurement of your cartridges, and we reduce the price for service to support and keep the machines running. So like you say, it's very challenging because they don't want to talk. So even getting a program to sit and consolidate the country's kits, which makes it cheaper for the countries to keep their inventory running, has been a challenge for us. So we are in the same pool. We've tried to bring solutions. And yes, if the gene expert is not being utilized, it's a big shame because it has the power for over 30 different tests that everyone should be using.
Yes.
Great, thank you. So did you want the lady just there for our final comment?
I'm Nara from Mongolia, so I just wanted to comment on the slightly better story. So we have been having Cepheid from the Global Fund for the TB and HIV, and as Lucia said, it's been like it's actually, we've got the funding, we have the machine, we don't want to use it for hepatitis, whereas Mongolia, the TB and HIV is a smaller problem. We are 3.5 million people, we have 380 HIV population, whereas 400,000 hepatitis population. And then the funding is so hugely different. We are talking about $2 million funding every year for TB and HIV, whereas 400,000 population hepatitis, $0. But then we were still not able to use the Cepheid machines. COVID did a lot of bad things for our hepatitis work, but did one good thing. That was we could actually share the Cepheid machine. Now, after 5 years, we have government made the decision that we actually share the machines, but still the procurement is, at the moment, we are fighting, okay, how much hepatitis cartridges are gonna be ordered or so. And of course, we had some issues with the hepatitis B cartridges. So hopefully, maybe in a year's time, we can actually use it. Thank you.
Yeah. Great. Yeah. Thank you all so much. Please help. join me in thanking our panelists. They're fantastic. Thank you so much for our first TB session at World Hepatitis Summit. And thank all of you. And we really look forward to taking all of this, everything we've talked about forward. So thank you
Yes.
so much. Yeah.